Good morning, everyone. Welcome to the Denver Museum of Nature and Science at home. I hope you all are safe and well and getting settled in with your morning cup of coffee or tea. I'm Kristen Uhlenbrock. I work at the Institute for Science and Policy, the project of the Denver Museum of Nature and Science. Our purpose with the Institute is to ensure that science is second nature when it comes to making public policy. Over the past couple of months, our lives have been upended by a global public health crisis, which is why we're here today. I don't know about all of you, but I've quickly picked up a whole new understanding and set of vocabulary words, such as flatten the curve, social distancing, PPE, most recently contact tracing, and of course, the coronavirus. And if you're also like me, you've been intimately following and at times feeling overwhelmed by the amount of information coming at us very fast and from every direction. Well, at the museum and at the Institute, we're trying to cut through all that noise and focus on the science. What we know, what we don't know, and what we can do to protect each other and our communities. So today, we're kicking off the first in a series of webinars to do just that. The museum is honored to be partnering with the Colorado School of Public Health. It's the first accredited and only collaborative school of public health in our region. It's a collaboration between the University of Colorado, Colorado State University, and the University of Northern Colorado. And we have no better person joining us than the Dean of the Colorado School of Public Health, Dr. John Samet. Dr. Samet is a pulmonary physician and epidemiologist and serves as a professor within the school's Department of Epidemiology, as well as in the Department of Environmental and Occupational Health. His research focuses on health risk of inhaled pollutants. Dr. Samet received his bachelor's degree in chemistry, like me, and physics from Harvard College, as well as his medical degree from the University of Rochester's School of Medicine and Dentistry, and a Master of Science degree in epidemiology from Harvard School of Public Health. I'm going to drop a link here in the chat with more of his illustrious career, numerous awards, and bio, so you can read up just a little bit more about Dr. Samet. So not only are his credentials impressive, but Dr. Samet is one of our leading state voices here about the coronavirus and the public health crisis we're under. How it's spreading, what is COVID-19, and how the different measures can be used to slow the pandemic. We're going to hear a little bit more about some of that today. He's been advising our state officials, as well as working closely with the Colorado Department of Public Health and Environment. Before I hand this over to Dr. Samet, just want to remind all of our participants, but first, thank you for joining us today, and that you can ask questions for Dr. Samet by using the chat feature kind of found at the bottom of your screen. Once he's done with his presentation, we're going to work those questions into our discussion with him. Without further ado, that I want to say good morning and welcome and thank you to Dr. Samet.
Okay, thank you, Kristen, and good morning to all. I see, looking at where you're from, the answer is all over. Okay, we should be ready to go. So thank you, and delighted to lead off the first presentation, this collaborative project between the Denver Museum of Nature and Science, the Institute, and the Colorado School of Public Health. As you'll hear, stay tuned for more. So let's start with what is a coronavirus. And the virus is so named because it has these little spikes making a crown, if you will, on the virus. So I'm just pointing these out. We've lived with coronaviruses for a while. There are 4 that cause the common cold. Not the only cause of the common cold, but there are 4 that are contributors. And then there are 3, let's just call them bad guys. The 3rd we've just recently learned about, but 2003, we dodged a bullet when the coronavirus caused illness SARS came and left. Far more lethal than the new coronavirus, but luckily did not become a pandemic. You've heard about Middle East respiratory syndrome, or MERS, and now we have this disease, COVID-19, and as you can see, it comes from coronavirus disease, COVID-19. A picture of the virus schematic is shown below. You'll notice the spike proteins. I've circled one of them. They're on the surface of the virus, and they bind to receptors in the lung and throughout the respiratory tract. And this binding is very, very important. They bind down in the lower part of the lungs so that the virus can cause this lower respiratory illness, pneumonia, that is so serious. The proteins, as we'll learn later in another talk, are also a potential target for a vaccine. Now, when we talk about transmission, and you've probably all heard about this now, droplets and aerosols. So just a little bit on basics. When we cough and sneeze, we produce large particles, droplets, and these are the ones that masks work for. When we put on masks, we're protecting others, our cloth masks, our surgical gauze masks, because we don't expel those larger particles. It can stay suspended in the air for a while. And again, that 6 foot or whatever radius is where people are exposed to those larger particles. We probably also produce smaller infectious particles as well, not caught by the masks so efficiently. And for healthcare workers and others needing protection, you've heard about N95 masks. These are ones that protect against the smaller particles. Then last, it's a strange word, but fomite, the fomite route of transmission, that's surface transmission. So we cough, sneeze, droplets settle, and they come on surfaces, we touch the surfaces, and the virus can be transmitted that way. So just some basics about why we want to wear masks and why we distance. We stay far enough away from people or from contaminated surfaces to avoid infection. Again, some terminology that we've all become too familiar with. Endemic is the disease that we usually live with. It's among us, that goes and it stays with us. Epidemic is when something unusual happens, when we have more disease than we expect in time and space. Might be a few cases, or it might be millions of cases. And if an epidemic spreads globally, it's a pandemic. Also notice here that these are epidemic curves, okay? The disease going up and then down. Here's an example of an epidemic curve you've all heard about, the Diamond Princess cruise ship. What's unique about this is we sort of have the whole experience of everybody who was on the ship. The timeline down here, the ship being quarantined in Yokohama after starting its cruise in January. You can see the curve for those, the orange, who are closely exposed on the boat. You can see those who are not so in close contact with the people who are infected. And then this later wave of blue among the crew. So you can see what happened is the epidemic started, several people perhaps were on the boat. The epidemic spread because people were in close contacts. Boats are not great for socially distancing, of course. And then the spread to the crew, and the total attack rate, the total proportion of people who eventually ended up having COVID-19, 19%. So we have that whole experience here on one ship, and you can see the epidemic curve, its rise and then its fall. Now, critical to ending the epidemic are the basic tools of public health and epidemiology. When I was at Johns Hopkins years ago, we talked about public health, protecting health, saving lives millions at a time. And when we've done our job well, no one knows we're doing it. But here, the epidemiology community, the public health community is pulled right into the fray of dealing with this virus in real time. This cartoon comes from 2001 at the time of the anthrax concerns. And this is one of those moments where everybody hears the word epidemiology and public health. Somebody's been doing epidemiology for decades. I still find myself explaining what it is, not these days. So one person we have to mention when we talk about infection is Jon Snow. You might read about him in this book, The Ghost Map. Snow, not the one from Game of Thrones, was able to identify waterborne transmission of cholera in London even before we knew that there was such a thing as a cholera vibrio organism. Use the basic tools and logic of epidemiology to do this, and this book tells that story. So let's turn to the epidemic now. And we're all bombarded every day with what's going on with the epidemic. It's inescapable. Just to lay out the picture at the moment, globally, the size of the circle here is, of course, proportional to the number of cases. You can see where the largest circle is, the United States, followed, as you'll see, by India, China with its smaller circle, and other countries. Australia and New Zealand think they may be bringing the epidemic to an end now. One of my fears that in the less developed countries of Africa, some of South and Central America, the epidemic could explode. I've been working in East Africa for about a decade, and they're just ill-equipped to deal with what could come if the virus were to explode there. Just to look now at some of the countries, on the right, you'll see a timeline for each of the countries on how the epidemic moved in time. Of course, China starting the earliest, and you can see where the United States is. This comes from Friday, and of course, this is now out of date because we're crossing the 50,000 mark in terms of attributable deaths. And then the United States. And again, of course, the tragic experience that the New York City and New York, New Jersey, Connecticut areas have been through. Here's Colorado. And of course, there's a great deal of variation in the numbers depending on where each state is in the epidemic and its size. But of course, the epidemic is everywhere at this point in its evolution in the United States. Turning to Colorado, these are case numbers by day. These are becoming challenging to interpret because as we bring in more and more testing, of course, we'll have more and more confirmed cases over time. So another perhaps more accurate indicator of where we are is the bad news of how many deaths we've been experiencing. And again, here is the death curve, the epidemic curve of deaths. And you can see what has happened. Our distancing measures have worked and the number of deaths has come down. And we'll come back to this when I talk about our infectious disease modeling that we have been doing. By county, again, it's almost everywhere. I know I heard the governor just say we didn't have any cases in Benton County. Of course, these are relatively low population rural counties, and the concerns are, of course, in the Denver metropolitan area, there was the early rise in the ski areas of Eagle and Summit County at the start of the epidemic. So you can see its distribution across the state. So let me talk about modeling. And this is now a critical tool to understanding what has happened and what will happen, as I'm going to describe. We put together a team about a month ago to do work on modeling in collaboration with the Colorado Department of Public Health and Environment, CDPHE, and within the University of Colorado at Anschutz, the School of Public Health, the School of Medicine, Boulder, Denver, and CSU, we put together a very diverse team that has worked very hard over the last month to provide results to inform policy. And what we do is look at different scenarios of what could happen depending on what measures are taken around social distancing, contact tracing, and so on. So here's some of our team, and here's a typical team meeting, a Zoom meeting of our team, which I can assure you has happened a lot day, night, and weekends over the last month. Now, what's a model? So a model is a representation. This is a Picasso picture. I've called this Picasso models a cow, because what he's done here is go from the full complexity of what a cow looks like to its elements. And what we're doing with our modeling is taking what happens during an infection and reducing it down to its component parts, as I'll show you, and doing a mathematical representation of the process. So here's a very straightforward picture. At the start of an epidemic, everyone is susceptible. In the case of the SARS-CoV-2 virus, we haven't seen it before. So none of us are immune, and we are all susceptible. As time progresses in the epidemic, here's the epidemic curve, people become infected, and as they recover, they become immune. Now, if it's unfortunately this virus, we know that some people are going to become very ill, and unfortunately, some people are going to die. You've all heard now about the R naught, the R sub 0, which is the rate of new cases per infected person. And that's a value that changes over time. It depends on places, depends on how much people are in contact, how infectious the organism is, and more. But that number is important in how fast this curve takes off, if you will. Now, models give different results. And I think there's been a great deal of confusion as competing model results are presented, and perhaps one suggests a peak at a particular level and one suggests a peak at half that level. This comes from last week's New York Times, showing the results of 5 models and 5 different peaks. Now, my takeaway from this is I'm not surprised the different models give different results. I think they all bring the same bad news, that there's going to be a very high peak of COVID-19 deaths. And that peak is roughly going to occur around the same time. So I think in looking at the models, the question is, if they lead to different policy implications, then we have to think very carefully about them. But just to have a famous quote, all models are wrong, but some are useful. So there's no right model here. You see this cartoon up above says, hey, I thought we were working with the same data. Mostly we are, but we're doing different kinds of representations. Our model that we're doing for Colorado is a biologically based model. It follows that picture I showed you earlier of people being susceptible, becoming ill, and recovering. We've now added on another box here. We've added on this box that says exposed. So we begin with people who are susceptible. Some of them are exposed. Some of them become infected. One of the challenges of this virus is that we know that many people are infected but asymptomatic. Those people are hard to find. They're more likely to be younger, and younger people are more likely to be mixing. Some of those who become symptomatic are infected. And then in our model, we actually add on here what happens in the medical care schema. We add in that people may be hospitalized, they may need ICU care, and then they may go on to recover, or unfortunately, some in this box, and we put this in the model, will need intensive care and perhaps go on and not make it. This also points to where we want to control. We want to keep those who are susceptible from being exposed. Social distancing keeps us from being exposed. Masking keeps us from being exposed. Contact tracing to remove those who are infectious from exposing others. And then down here, isolating symptomatic cases, of course. So when we do these models, we vary how much people are socially distancing. We can look at behavior by age. We look at masks, and we look at epidemiological control measures like contact tracing, like isolation. So here's what I'm going to show you a little bit of the results of the models. And here's a timeline of what's happened. Of course, we're up to April 27th, the day that the new governor's new Safer at Home kicks off. And here's some of the things we did before. I think beyond the orders from the governor and the counties, we've all changed our behavior. So I think that's all incorporated in the models I'm going to show you. We've done two things. We've looked backwards to say, what happened? What was the impact of all our behavior? What did we do to the rate of infection? How much social distancing did we achieve? And then for policy, we've said what will happen as we use different scenarios of control measures. So what we wanted to do early on was to avoid this red peak, a peak where our healthcare system capacity would be overwhelmed. And of course, you heard about the stark choices that we would have to have made had we reached that point. Does this person get a ventilator while this one does not? Imagine coming to that. Well, luckily we didn't so far. So the goal of social distancing was to bring the curve, sort of flatten the curve in a way that we don't exceed healthcare capacity. So that has been the goal of our social distancing measures, to avoid the red peak and create something that looks more like the blue peak. So what have we done? This is a look at the cases occurring by the time of the date of onset. And what we've done here is use our model to say, how did this curve bend? How much social distancing did we achieve? And the governor talked about this about 2 weeks ago, that we had done a good job and that things were beginning to bend. And you saw the death curve, the curve of deaths previously, where things had bent down. So early on, it took a while to see this, the measures on March 17th, and then more recently, the measures on March 26th have had their beneficial consequences. That's good news. Now, then we look to the future. Now we're going to take on that future look, the projections. We're going to look at our tools, social distancing. This is the Abbey Road cover. I hope most of you recognize that, with the Beatles socially distancing. We want to protect the vulnerable. Over 90% of the deaths in Colorado are in people who are 60 plus. Case identification and tracing. This is from a bus in Wuhan, where one individual set off a little mini epidemic among people sitting near him or her. Contact tracing, and you've heard now a lot about whether we're going to have new tools to do that, including use of apps, cell phones. And then, of course, masks. A fabulous picture of our governor greeting Vice President Pence, one mask wearer among the group there, as you will notice. So here's a somewhat complicated curve, but let me take you through this. So these are projections. This is approximately today, April 27th, the white arrow. And these are curves saying what happens if we just use social distancing as our tool moving forward. And let's say we're now at 75 to 80% social distancing. We lighten up, and we lighten up to different degrees, ranging from 35% to 65%. Here's roughly where our capacity to deliver critical care lies. And what we want to do is keep these lines below, the curves below that line. And you can see it's sort of an oops here. Social distancing alone won't do the job. So we look at another scenario now where we've brought in all our interventions. This is going to be ensuring that the older people are protected, that we are using masks, that we are identifying and isolating cases, and we'll be building in contact tracing here as well. And it looks like we can then keep that line below, keep that curve below where it needs to be, that dashed line. But we have to use all our tricks. One consequence of the social distancing has been that most of us have not been infected. Most of us are still vulnerable once we relax the restrictions. It's important to keep that in mind. We've estimated that maybe perhaps 1.5% of Coloradans have actually had the virus, been infected, and are hopefully immune. That leaves most of us still at risk. So we have to be very careful as we lighten up social distancing. The goal, of course, is to get to a point where we either have a vaccine, here's Dr. Fauci, when we have a vaccine, or to have enough of us infected that we reach the point of herd immunity. This is probably the world's only herd immunity cartoon, Bob sitting in the middle of a herd of cows. That's not quite the way it works. Herd immunity is when we have enough of us have been infected and are immune that the virus can't propagate. That R naught value is lower than 1 because there's not enough people to allow it to go above 1, which means we have epidemic conditions. So I'm afraid that having a vaccine, I think we know, is sometime off in the future. Probably saw in the paper this morning that Dr. Burke said we're going to have social distancing at least through the summer. I think that is certain. I think how much longer it will go on, how we can manage the epidemic remains dependent on many things. So I'm going to close with a reading recommendation. John Barry's book, The Great Influenza, published in about 2004 and rising on the bestseller charts recently to as high as number 5 or so. The lessons from 1918 still work. So I'm pleased to have had the opportunity to launch this series, to speak with so many of you. I know we all want to have as much information as we can, and just to show how deeply the social distancing is penetrated. Here's grandson Nicholas making sure that his brown bear is properly masked. So I'll end here, and I look forward to having a conversation with you about your questions. Thank you very much.
Great. Thank you, John. Dr. Samet, that was wonderful. Really accessible, hits on a lot of key points here. We have a ton of questions coming in. So thank you, everyone. Keep your questions coming in. Let me just say out of the gate here, if we don't get to all of them, we'll give you an email address and we'll figure out how to kind of get those answered for you if we can't get all of your questions answered in our short time we have remaining. Let us start off and kind of go back to the beginning of your presentation a little bit, Dr. Samet, and you were talking a little bit about SARS and MERS and how that compares to COVID-19. Could you speak a little bit about why those did not become such a big pandemic as COVID-19 did?
Well, they're both signature diseases. And what was notable about SARS, severe acute respiratory syndrome, was how severe it was. Very high case fatality rate. And the cases could be more readily identified. I don't think we had this problem of asymptomatic infectious individuals. And of course, the Middle Eastern respiratory syndrome has originated in the Middle East. It's involved contact with camels, a carrier. And the cases that have spread outside of the Middle East, South Korea had a substantial epidemic, were containable by contact tracing. There, the case was brought in by an individual who had been in the Middle East. Here we have a disease that is no different from influenza in many of its manifestations or other respiratory viruses. So there's just too much going on, too many cases to use these containment methods that worked for two very serious diseases, but with very different epidemiological features.
Great. So let's switch specifically kind of to the US, and then we can maybe narrow in into Colorado. So we've had some questions come in about why the US has the largest number of cases. And then let me build on to that because some of these questions follow up a little bit, which is maybe you could talk about, you know, the US as a whole, and then talk about a little bit about why there's reporting on number of cases versus number of deaths. And kind of the difference between reporting metrics and what is, you know, what makes the most accurate sense when you're talking about the pandemic and the epidemic in Colorado. And then take that one step further, because I think these all tie together, and talk about reporting things such as deaths per 1,000 people or number of cases per 1,000 people and showing that ratio between the US or Colorado with other countries. Could you talk us through a little bit of all those pieces?
Sure. I wish we had a couple of hours and then we could really probe into these issues. But, you know, I mean, I think the question of what happened in the United States and where, I think I'll just start very simply with saying that we weren't prepared as well as we should be. And that's probably we at all levels. Many have forecast the possibility of a pandemic like the one we are experiencing. And I think at many levels, and I don't want to point fingers in any particular direction, we weren't ready. I think added on to that is the globalization that just fostered the spread of the virus into our country in so many ways. When it actually arrived here, did it have a long silent period, as Northeastern University modelers are suggesting? We'll probably learn more about that. Colorado, I think, illustrates some of the complexities of globalization, with the ski areas being hit. As I recall, there's a family from Australia who were infected, among others, coming into our close-knit environments and starting the spread. And once that spread had started, it quickly moved, you know, throughout the country because of our fluidity and because of our movement. So I'm not surprised that how we ended up where we are. I'm sure we're going to be reading books and retrospectives on this for years to come. I mean, my hope would be that we come out of this with better preparedness for the next pandemic and for continuing to manage this one. One question that comes up is, what is the best way to track, which I think lies with this question of deaths and cases. And then I think everybody's heard about this so-called Stanford study, the study done in Santa Clara County. There's a study going on in Los Angeles about prevalence of people with antibodies indicative of infection rates, figure of 20% from New York. We really do need to get a good handle on, an ongoing good handle on how many people have been infected, have antibodies, and are hopefully going to be immune. That remains a question as well. We'll need good surveys to do that. We'll need good antibody tests, and it seems like we're still struggling even to get accurate antibody testing. So I think that long ramble addresses most of the issues raised, Kristen, in your question.
Yeah, no, that's great, Dr. Stamett. Thank you. It actually leads to a lot more questions we're going to have. So let's maybe just take this moment and dig a little bit deeper into some of that. And let's take one step back, though, and talk briefly, because we've had some questions about that reproductive number, or R naught, maybe people have heard it said. And you briefly talked about that here, and the idea of that kind of reproductive number being less than 1. One of our participants has come across a new site of data called rt.live.
Right.
Is that a reputable source of data? Because they're looking at that monitoring, looking where Colorado, it has all the states for those who have not seen the site listed. Right. Is that a reputable source of data and information? And could you just briefly talk about that reproductive number, that R naught number that people are hearing a lot about?
Right, sure. So, you know, the R naught, I mean, just to make an obvious point, is we want to be below 1. And not above 1. And essentially there's a relationship between the social distancing measure and the value of our naught. And you can imagine that if we were, you know, perhaps Wuhan style quarantine, all contained within our buildings and not allowed to go out, our naught would be heading down towards 0. I think it was down to 0.33 or some such estimate in Wuhan. So R naught is variable. The idea of the RT side, I think I know this one, is to track it in time. We've been talking about some similar kinds of tracking, providing that number to the public. I think, and maybe anticipating some of the things I see here in the chat, it's going to be really important that we have a good handle on what is happening as we lighten up the restrictions. We don't want that R naught value to go back up. There'll be tracking of how well we're doing on maintaining social distancing, the needed social distancing, through some of the cell phone data sources that are being used, through, for example, tracking traffic through the CDOT data. And we'll try and get a handle on how much mixing is changing, because that's going to be one of our earliest warnings if we've gone too far in returning to normalcy.
Great. What about how long does a virus live on? This is a very, question I think people are concerned about. How long does that virus live on a surface?
Yeah, there have been some studies of that in experimental systems, and in part it depends on the surface, but sort of around 24 hours seems to be the estimate in the literature. If you go, there actually been some studies in the New England Journal of Medicine on this, looking at different kinds of surfaces, but I think 24 hours, paper, cardboard seems to be the right number. I will say that many of the medical journals are posting article after article after article. It's hard to keep up, but for some of your questions, you may be able to go and find articles that are posted, because there's just a myriad of them.
Thank you. And can you be exposed and not be infected?
I will make the assumption that yes, that answer. Look at the attack rate on the Diamond Princess, 19%. And for whatever reason, and I'm not going to speculate too much whether it would be the actual number of organisms encountered or variations in the immune systems of different people, whatever might make us more or less susceptible. The answer seems to be yes. Now, I will say, of course, that's complicated by the fact that we know many people can be infected and asymptomatic, so we may not pick them up. But I think the answer would appear to be yes.
Mm-hmm. And building on that, someone's potentially infected, asymptomatic, there's this question around, knowing the true number of how many people, have COVID-19 or the coronavirus. And if someone becomes infected, can they become immune to it? This goes back a little bit to the questions you raised about antibody testing. Right. Could you speak a little bit to that?
Yeah, that seems to be an unknown question. And, and again, in reading about this question, do the antibodies persist? There's some data from the SARS epidemic, from those who were infected, that over several years, antibody levels waned. There have been suggestions that perhaps we can learn from animal experiments. Mark Lipsitch, a very good infectious disease epidemiologist at Harvard, has suggested we may have to do some challenge studies in which people who we think are immune are actually exposed again to see what happens. The persistence of immunity is going to be critical for the long-range management, assuming that this virus stays with us.
Mm-hmm. Regarding vulnerable and vulnerability populations, a few folks have asked about this. One is, are certain blood types more vulnerable to COVID-19?
Yeah, sure.
I don't know if I've heard that. Yeah. Mm-hmm.
I don't think I've seen any data on blood types or other sort of markers of our genome as to what might make us more susceptible. I mean, of course, for more severe disease, we have some indicators. People with underlying disease, age seems to be critical. Men are not doing as well as women. Smokers seem to be at greater risk of more severe disease. Not aware of anything on blood type.
Mm-hmm. And then, someone asked about having a compromised immune system being more vulnerable. You spoke a little bit about kind of elderly populations, but people have also seen healthy immune systems, and people get this virus and die from that. How does anyone know if they get ill, how they'll survive, or what they should expect?
Well, yeah, I mean, there have been some startling cases, of course, deaths in young people from overwhelming pneumonia. So it would seem that nobody is at no risk. I mean, I think that's a statement that can be made for having more severe disease. And then after that, the risks just go up with age and quite sharply at 60 plus. So I think that's all we can say. But clearly, young people have a great advantage of infected in terms of having a good outcome.
Should people be wearing masks? Whether that's in a suburban neighborhood, outside, could you talk a little bit about where and how people should be wearing masks?
Sure. I mean, remembering that masks are where we're doing our part for others. And, you know, unless, of course, you're wearing equipment that will actually protect you. But the kinds of masks that we're encouraged to wear should be worn. They will protect others from these larger droplets should someone be infected. I think they're a good reminder of the fact that we're in this pandemic setting and that we need to be maintaining social distancing. I don't see any downsides to wearing a mask. It's a real no regrets strategy with benefits when we examine masks, use of masks in our models.
Mm-hmm. And what about contact tracing? How set up are we here in Colorado to deploy some of that? And the second part of that someone was interested in is the role of CDPHE, which is the Colorado Department of Public Health and the Environment. How well are they set up to kind of go into these localized approaches?
Right. So, you know, contact tracing is going to be important for the longer run. Both CDPHE and the local public health agencies are now gearing up to do contact tracing. There's a great deal of discussion about how to be coordinated, address contact tracing at the state and local levels. CDPHE has a critical role here as the state's public health agency, along with its local partners. The point person for CDPHE, must have one of the toughest jobs in the state at the moment, is Rachel Hurley, the state epidemiologist who, you know, has this coordination of activities. Beneath her, of course, there's the incident command structure, all our preparedness as well. So CDPHE is one of the many state agencies that is involved in dealing with the epidemic.
Dr. Samet, we are coming up close on our time. So I want to leave you with any final parting thoughts or remarks you have, or maybe a couple top key resources that you'd encourage people to go look at for more information.
Right. So, and I noticed looking at the chat that I'm sorry we're not getting to your many questions.
Yes.
But we will take a look at them and try and provide some answers, because there's a great deal of thought in all the issues that you have raised. You know, there's an awful lot of resources out there. CDPHE's website I would recommend. We are posting our models at the Colorado School of Public Health. We have a coronavirus page. CDC has many good resources as well. And then that said, I would caution you against what I would call the not so good resources as well, because there's a lot of misinformation circulating. And I think if you hear something that sounds maybe not likely or perhaps misleading, you know, check back with these reputable sources of information for sure. I think, you know, just a comment, we're in this for the long run, and I think we're really all going to have to work together, do our parts, whether it's masking or distancing, to assure that we stay as healthy as possible. So again, thanks to all, and stay well.
Thank you, Dr. Samet, so much for your time. I know extremely how busy you are, and we really appreciate you giving us the time here to speak to the museum community and broader with all of your expertise. I am so sorry we could not get to all of your questions. They were wonderful. I did just post our Institute email address in the chat feature. If you want to send us questions, we will try to get those answered by experts like Dr. Samet and others, and try to make sure, you know, we're providing you with as much accurate resources as available. So please do take the opportunity and email us. I do want to kind of close up. I've heard a lot of people saying this recently in op-eds and in other kind of outlets, and it's really resonated with me, which is, people have been saying we're all caught in the same storm, but we're not in the same boat. And I think that's a challenge with all this, is thinking about kind of we're all in this together, we're all dealing with it, but we all have very individualized experiences. So I encourage you to really look for those trusted sources of information, like Dr. Samet was pointing out, and really make sure you're getting the most accurate information for you and your family, and trying to do what you can. We're going to be part of a series. So our next event is going to be the same time, same place in essence. So I hope you'll join us on May 4th at 8:30 a.m. Mountain Time. You can share the link wide with your family and friends when you register. We're going to have 2 more experts next week. So next Monday morning at 8:30, we're going to be hearing from Dr. Thomas Campbell and Dr. Michelle Barron. Both of these experts are professors of medicine and infectious disease at the University of Colorado School of Medicine. They're going to be talking a little bit more with us about where we are when it comes to a vaccine and what is the role of therapeutics in helping with the coronavirus. You'll find our link to register for the next webinar on the museum website. That's dmns.org. We're also going to be posting it to our social media channels, so you can follow us on social media on Twitter at Denver Museum NS for the museum. You can follow the Institute at Institute SciPol, that's SCIPOL. You can also follow the Colorado School of Public Health on Twitter at Colorado SPH. All 3 of those accounts will be sharing out links for more information, how to register for upcoming webinars. A huge thanks again to Dr. Samet, as well as the Colorado School of Public Health for all you're doing, as well as to our frontline workers and our medical professionals. I do want to leave us all with these parting thoughts from our tireless leader here at the museum, George Sparks. He likes to say that we should be kind to one another. So I encourage you all to stay healthy, stay safe, be well, and be kind to one another. Thank you very much for joining us today. We look forward to seeing you at a future webinar.